Health and also Associate Professor in the Department of Family Practice in the Faculty of Medicine at UBC. And thank you for joining us and the team today. Before we begin, I'd like to gratefully acknowledge that the UBC Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people. And the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places. I'm joining today from the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. If you wish, please share the lands from which you are attending in the chat. It's a privilege to connect, live, and learn here, and I'm grateful to the traditional caretakers and owners of these lands. I'll pass over to Christy.
Thanks, Lee. I'm joining from St. Mamet, which is now called Port Moody, the traditional unceded shared territories of the Coast Salish people. As Lee has said, I am the Associate Vice President Health, and the TBC at UBC Network is supported and coordinated by the Health Systems team of UBC Health, which works under the Office of the Vice President Health. And the mandate of UBC Health is to facilitate and enable collaboration across disciplines, faculties, external partners, and communities to improve the ways we train people, develop knowledge, and shape policy to ultimately address health inequities and improve the healthcare system. And the aim of the TBC at UBC Network is to bring people together across sectors and communities to help address complex challenges affecting the health and well-being of our population, and to bring forward questions and ideas that are important for team-based care in BC. The network supports and complements province-wide efforts to enhance team-based care in British Columbia by focusing on the academic realm, education, research, evaluation, and knowledge translation, and by enabling participants to learn from each other and connect with their efforts. And now I'm going to head it back to Lee.
As we get going, we like to open with a poll, which we'll get going, to see who's joining us today for this session. And if you could respond to the poll with the perspective that you are bringing into the session today. So will you be joining as UBC faculty or staff, as a student, as a health professional, patient, community member, health administrator? We're just waiting for everyone to finish the poll. I'm waiting for my team. Once they turn it over, then I can see the results. And we'll share with everybody what perspectives we have. Oh, excellent. Looks like we have a complement of folks from UBC, faculty, staff, and students. We have a good number of people from health authorities, health administration, and government in the room with us today. That's great, can help with any barriers that come up. Health Professional Association and clinicians in the room as well. And proportion of patients and community members, as well as researchers. Excellent. We have a wide distribution. That's so great. Thank you. Thank you for taking that time. Today's session is curated to be an engaging dialogue about the ongoing initiative led by UBC's Innovation Support Unit to support team-based care in BC. This work focuses on implementing learnings in practice and was developed collaboratively with primary care partners to better understand the current benefits of team-based primary care in BC across several different models. During our time together, we'll hear insights from the first round of evaluation and talk about how we can use the provincial level findings to make improvements at local and regional levels. So how do we take the learnings and bring them down into our practices, into our communities, into our regions? We'll also have the opportunity to discuss practices for engaging patients in primary care evaluation. So in terms of the structure, it follows the same pattern as many of our events. We'll start with a presentation from the ISU team. And after that, we'll transition into smaller group discussions. We'll have two breakout discussions today focused on two topics: quality improvement in primary care and patient engagement in primary care. And then finally, at the end, we'll reconvene as a large group to share highlights from each breakout room and discuss how to continue these conversations moving forward. So without further ado, I am pleased to welcome Elka, Ada, Angela, and Nina from the Innovation Support Unit. Thank you for joining us today. I'm super excited for the updates and the dialogue, and I'll invite you to introduce yourselves as you begin.
Thank you, Lee. I'll just share a screen here. Hi, everyone. Thanks for joining. So I'm Elka Humphreys. I'm from the UBC Innovation Support Unit. And we're here today to share learnings and reflections from the BC team-based primary care evaluation. So next slide, please. The ISU is a distributed team, so we gratefully acknowledge the ancestral, traditional, and unceded territories of the Coast Salish people where we live, work, and play. And just to give a few introductions for the team who's joining us today, obviously there's myself, and then there's Angela, Ada, and Nina, and we'll be facilitating the discussion in the breakout rooms. So just a brief agenda for today. We're going to go over some background and context for the evaluation, then talk about the design, so how we're moving from evidence to action, discuss some of the emerging evaluation learnings, and also the reflections of the evaluation so far before moving into the discussion in the breakout rooms. So firstly, to go over the background and context. So next slide. The TBC evaluation purpose, so why we're doing this, is to better understand the current positive benefits of the transition to team-based primary care across BC. We're using our team framework as the theoretical framework for the study. So this is a 10-dimension evaluation framework. And for this evaluation, we're focusing on patient experience, provider and staff experience, team function, capacity and access, and then also attachment. And just a brief overview of the evaluation inclusion criteria. So in round one, we focused on mature teams who had been working together for a year or more. We've now moved on to round two, and for round two, we're also recruiting new and emerging teams. So teams that have been working together for at least 3 months. Within that inclusion criteria, we want to recruit teams that have had minimal staffing changes within the past 3 months. And also teams must include a minimum of 1 family physician or nurse practitioner, 1 other clinician from a different profession, and 1 administrative support role. So I will pass over to Angela to talk us through the evaluation so far.
Thank you, Elka. Yes, and thank you everyone for being here today and to UBC Health for having us. My name is Angela and I'm a project lead with the ISU leading this evaluation work. So now moving on to what this evaluation looks like, moving from evidence to action. So I think Ada has just put in the chat the link to the evaluation recruitment poster. And we're going to be saving some time at the very end to talk more about the evaluation for those who have questions or who might be interested in participating. So as an action-oriented evaluation, we want this work to be really useful for the primary care teams involved and for provincial leadership to inform policy and decision-making. So we're looking to engage about 30 teams from across the province in the evaluation, and we split this work kind of into 2 rounds, as Elka has talked about. So after each round, we're summarizing the findings and conducting what we call a provincial constructive workshop. So we work with provincial leadership to help them make sense of and utilize the findings from the evaluation. We'll get more into what a constructive workshop is in a few slides, but essentially earlier this year, we ended round 1 a bit early to meet an informational need from the ministry, and we discussed with them whether the evaluation and the data that was gathered meets their needs and what's missing, and then discussed what's going to happen in round 2. And then the provincial workshop in round 2 is going to be focused more on policy and decision making and how that can be informed by the data. So this is what the evaluation looks like at the clinic level. So we're working with clinics and health centers across the province, primary care teams, however that is defined by the teams themselves who are participating. And this is what it looks like from the data collection phase to action by the clinic team. So we're using 3 tools to gather information. The first is a patient survey assessing the patient experience with a focus on person-centered care and the perception of team-based care. The second tool is a team survey for all providers and staff on the primary care team to assess team function, so how the team is working together, and the provider and staff experience of working in the clinic or health center environment. The final data collection tool here is a clinic report. So this is something that's completed by one person on the team, and it's a survey that asks questions about the clinic context, such as the types of professionals on the team, whether they see attached and unattached patients, what access looks like for them, and what structures are in place to facilitate team-based care. So our team rapidly analyzes this data that I gathered from the clinics and brings it back to the clinic for discussion. So from our perspective, the most valuable and unique aspect of this work is the clinic constructive workshop. So this is a about 2 hour session with the clinic where we share key findings and facilitate some activities with them to think about quality improvement actions informed by the data that was gathered. We then follow up with the teams in a few months to see if they've implemented any of the ideas. This whole process takes about a month with the team. So what is a clinic constructive workshop? A clinic constructive workshop is a workshop that focuses on engaging participants in building on an idea to move it to action. So in our workshops with participating clinics, we focus on a few key findings from the evaluation, and we engage with team members to explore those ideas and how they can inform quality improvement. At the end of the 2 hour clinic constructive workshop, we want to have about 2 co-created QI ideas that the clinic can move forward on. So why a workshop and not just a presentation of the data? We find that workshops are more engaging, so it gets more people's voices in the room rather than just our voices as the evaluators presenting findings. It also gets the clinic thinking about action. So it supports them to move forward with the evaluation findings, and we kind of get them started on that process of thinking about quality improvement. We also try to set them up to move forward with those actions by providing resources and recommendations, and also connecting them with coaching supports if they're not already connected, or encouraging them to connect with the coaching supports they already have. And then the workshop discussion can also help us make better recommendations in our reports. So after each clinic constructive workshop, the clinic will receive a report with a summary of the findings, because it helps us understand what's feasible for the clinic and relevant, and what they're excited about in terms of QI. And so what makes a good clinic constructive workshop? How do we actually do this? So a good clinic constructive workshop is focused on a few key learnings. So it's not showing everything that might be interesting from a research or evaluation perspective. It's really focusing on what's feasible in terms of thinking about QI. It's visually engaging and clear. So we try to present data in a very clear and concise way that's easy to understand. It's relevant for the audience. So is this something that the clinic team is interested in and is realistic in terms of them moving forward with the ideas? Is interactive engaging? So we include some activities to get people's voices and thoughts in the room and really engage everybody in the team. and it includes the right people. So with these clinic constructive workshops, we invite all team members, so staff, providers, clinic leadership, to be involved. And then we also encourage teams working with coaches or other team-based care practice supports to include those people in the workshop as well. Now that we've introduced a bit about the evaluation process, we'd like to share a few of the key learnings from the evaluation so far. So we've triangulated findings from all 3 of the surveys across the teams who've participated, as well as additional context from the clinic constructive workshops we've facilitated. And this summary of data really represents a snapshot in time. So between August and December 2024, we gathered data from 8 primary care teams in BC. Across these 8 teams, 169 team members completed the team survey, and 694 patients completed the patient survey. Here again is the team framework that Elke introduced. I just want to note that we won't show everything that we've learned from the evaluation so far in the next slides because we only have a few minutes, but we're going to focus on 1 or 2 key learnings related to each of the areas we're assessing, so those that are bolded here in the figure. So starting with patient experience, patients generally provided positive feedback about their experience and their perception of how their healthcare team is working together. When asked about their perception of how their primary care team is working together, including both clinical and non-clinical providers or staff, more than 80% agreed with the following statements. So the right providers are involved in their care, their team is effective, they trust their healthcare team, their team communicates well together, works well together, and their healthcare is well coordinated. In terms of capacity, access, and attachment, data gathered suggests that team-based care helps teams better manage their existing capacity. Teams reported that working as a team, they're able to provide quality care and timely access to care has improved for patients. The data also suggests that larger teams with more nurses and/or allied health have capacity to support populations with complex medical and social needs and considerations. We found that as team size increases, so there are more other professionals involved in the teams, the percentage of patients reporting 5+ visits in the past year increased as well. This shows a strong equity focus in these larger teams that participated. So as Elke mentioned, in round 1 of the evaluation, we specifically worked with high-functioning mature teams. That was something that was self-identified by the clinics and through some conversations with us. And this was really reflected in the team survey findings. So across the 8 teams, providers and staff provided very positive feedback about how their teams are working together in terms of communicating with each other, collaboration, having clear roles and a team purpose and vision. When we asked about what factors contribute to a high-functioning team, teams identified the following. So having regular team meetings, that looked a bit different in each of the clinics that we worked with. So having weekly meetings, monthly meetings, maybe setting aside time each month to really focus on team building or team-based care, having daily huddles, basically having specific connection points between team members that works for the team. The second factor was having a shared purpose and mindfully building their team. So all of the teams that we worked with identified that they have a shared purpose. A few of these teams had it formally documented. And one team specifically mentioned that they actually review their shared purpose at every meeting to help ground their work. The third factor is co-location. So 4 of the 8 teams have all team members physically co-located. The other teams had kind of different combinations where some folks might be virtual or some sort of hybrid setup. And then they had some other processes and methods to communicate and collaborate together in those contexts. It was noted, though, that having that shared physical space with everyone in the same room can really allow for enhanced communication and collaboration. So, for example, this could look like walking down the hallway to consult on a patient or seeing if another provider or staff member is free to help a patient who is in the clinic currently, or working in a space where you can turn to the colleague beside you to ask a question about patient care and kind of get that feedback in the moment. And then the final factor was strong clinical leadership. Now looking at team experience. So we also asked providers and staff about their experience working in the clinic environment as part of the team. As you can see here with the darker purple bar on the graph, on average across the 8 teams, providers and staff feel they have a highly supportive work environment. They shared that working as a team has improved their work experience. It allows for them to collaborate on patient care, just as I mentioned, and develop their professional skills and provide good patient care. One provider specifically mentioned as well that team-based care has kept them in practice. And then finally, we looked at workplace and EMR stress as part of the team experience as well. So providers and staff across the 8 teams expressed some challenges around EMR stress and the frustrations caused by their EMR, work balance, and working in a busy atmosphere. Specifically related to EMRs, teams noted that EMRs don't always support team collaboration. It can be difficult to document collaboration. There's an added admin work piece there. And that there's room to optimize EMR efficiency. So some teams express interest in specifically focusing their QI efforts in the workshops on learning more about their EMR, how to use it really to its full capacity. And finally, we'd just like to share some reflections on the evaluation so far. So our first reflection is that it can be challenging for primary care teams to find capacity to be involved in evaluation because of many competing priorities involving patient care, maybe other initiatives that they're partaking in. And we've really noticed through our conversations with partners and our relationship building through this work that there are several different initiatives across the province that can probably be aligned. Our second reflection is that the constructive workshop can help teams move from evaluation to action. So it's been really rewarding to facilitate these workshops and be part of that experience. And nearly all of the participating clinics that we worked with reported that they have implemented or plan to implement changes following the constructive workshop. So this is when we followed up with them a few months after the workshops. And they found it to be a valuable experience. And then finally, patient experience is really crucial to this work, but we recognize that we need to be flexible in our approach to make it equitable and accessible. So as was mentioned at the beginning, one of our discussion questions today is on patient experience and really best practices around engaging patients in evaluation in primary care settings. So we're really looking forward to discussing that and hearing everyone's ideas or maybe some challenges that people have encountered. So that's in terms of our formal presentation today. And the next part is having a discussion. So we have a couple of discussion questions. And I think I'm meant to turn it over to Christy here to introduce the discussion questions in the breakout rooms.
Great. Thanks very much. This was an excellent setting the context presentation for us. I feel like it was a bit of a teaser and would love to learn more about the other features of the framework and also some of the clinic constructive workshops that and what the QI projects were, whether there was any sort of overlap in those. And I also love the concept of constructive workshopping as a process to sort of co-create and co-own the next steps. So thank you for that. As Lee mentioned, and you have mentioned, we're doing 2 breakout rooms. And participants will be able to select which room they want to join based on the topic that interests them the most or that best align with their role. The list of rooms should appear, and you can click join to enter your chosen room. And if you don't see a prompt to join the breakout rooms, click the breakout room button at the bottom, or at least in my screen, it's the bottom of the Zoom controls to select a breakout room. And the instructions are also going to be posted in the chat. So again, breakout room 1 will be the quality improvement in primary care, and breakout room 2, patient engagement in primary care. And we'll have about 20 minutes for the discussion in your breakout room. There are facilitators in each to help sort of prompt and guide the conversation. And we really do encourage you. This is your opportunity to ask questions, share your experiences and ideas. And then at around 10 to 1, we'll all come back together and perhaps share some of the highlights that came out in your breakout session. And the breakout sessions will not be recorded. And so jot down notes if you want to bring them back to the large group as well. And then if you have trouble joining, please stay in the main room, and then one of the team can help you get sorted into a breakout room.
Each speaker, each person just built on the next or connected the ideas together in the room that I was in. And I think with our last few minutes, I'd like to invite the facilitators from each breakout room to briefly share some highlights from their group discussions. I'm looking up at you, Angela, and I see you.
That sounds good. Yeah, unmuted
Fantastic.
there. Yeah, thank you, Lee. Yeah, I think it was a really great discussion, and we had people joining from lots of different perspectives, which was really great. So some of the best practices in terms of patient engagement that we talked about is having a really clear purpose from the start, and kind of clear understanding of why patients are being engaged in this work, what the purpose of the evaluation is, and having that really clear from the outset. Being equitable in terms of our engagement and having compensation. And I had added to the group that within this evaluation, we're really fortunate to be able to compensate patients for completing the patient survey. We also talked about engaging patients early in the process and thinking about accessibility. And the idea was put forward of when engaging with patients, bringing in a mentor or coach and really creating that welcoming space so that patients feel very safe and comfortable voicing their concerns, their considerations, their ideas. And some of the challenges around patient engagement that we discussed, longitudinal engagement. So having patients involved in the entire process, as I said before, kind of involving them at the very beginning, ensuring there's that kind of release of power and patients are kind of really meaningfully involved in that work, and having clear responsibilities and kind of expectations. And then at the very end, Christy was just cut off talking about our kind of lack of standardized approach to things like patient experience surveys. So we chatted a bit about some of the kind of patient tools that exist out there, and a need to align some of those and kind of trying to find a best practice or a standard there.
I'm going to jump in. The end of my sentence was, it's too bad that we couldn't somehow indicate with this survey that we're using that it is, iteration number 10 that has combined, this survey, this survey, to meet the needs, so that it acknowledges the work that's done before. It also acknowledges that those resources that were used to develop those earlier formats, haven't been wasted. They're not just collecting dust on somebody's shelf. We don't have a good way of doing that, right? Of that iterative, oh yeah, this is actually version 10 that combines these other ones. Anyway.
Exactly. Yeah. I'll just add that we do have a document that we put together that doesn't necessarily reference every survey tool that we've looked at in terms of our research, but kind of gives a summary of how we developed the tools. And part of that was working with partners. So we did actually work with PSP and talk to them about their patient experience tool that many people are familiar with, and then tried to kind of really lean on some of the previous provincial patient survey work that's been done. To make sure that there's some continuity in terms of those questions, and yeah, making sure some of that work that was done by experts before is used. Okay, I'll pass it off to Elka.
Thanks, Angela.
Elka, maybe before you start, If I may, I forgot before we started just to mention that we've opened a Slido for folks if you're interested in sharing any reflections. The Slido, the link is in the chat. It's anonymous, and if it'll help us better understand what's resonating with you and make sure we capture the most important things. The responses won't be displayed. It's really just to get more information to us in the background. And to help us collect and record your thoughts. So it's there, it'll be open. Feel free if you wish to go in and add any remarks. And now, thank you, Elka, for letting me jump in there. I'll pass over to you.
Thanks, Lee. Yeah, so our group was talking about the enablers and challenges of quality improvement in primary care. And Ada did a great job of capturing the discussion and also what was going on in the chat as well. So I think sort of some of the enablers that were coming out was really kind of having the right people involved in QI. So perhaps collaborating with a QI coach or having like admin support, so maybe the clinic manager, so that it doesn't take away from actual like clinical time. And also having people who are keen on quality improvement as well. And then, yeah, just also around sort of appropriate communication channels. So being able to kind of share what QI efforts are going on so that people can learn from each other when it comes to QI and we're not kind of doing the same thing in silos. And really having that kind of patient-centered approach to QI when we are doing quality improvement in primary care. And so then just kind of thinking about challenges. We did kind of go off that sort of siloed thought around sort of teams working in silos. And maybe there is some kind of opportunity to reduce those silos across teams and get kind of teams to learn and work together, perhaps on QI. And then again, there was sort of the do we have time to conduct QI activities if it's not built into the role or the healthcare systems? And then leading from that, also maybe QI isn't the right term to use. So perhaps QI makes it sound like it has to be this bigger thing than what it does need to be. And actually, teams are doing QI every day. They are looking for opportunities to improve in primary care. And so maybe thinking around sort of other phrases that we can use to describe this sort of quality improvement and what teams are doing. And then just also having sort of the training to be able to do the QI and being able to communicate the findings with patients. And I think like a future potential could be using AI to automate some of the evaluation process and QI activities. So that was an interesting thought to have in there as well. I'll wrap up there just because I know we're coming up to 1 o'clock and I want to make sure that the team has enough time to move on to the next piece.
Any comments related to that, the second summary there? I wanted to give others a chance before I jumped in because it always triggers my I guess my wheels turning and you know, and so perhaps a conflict or a bias. I am involved in the Health Data Coalition and would love to see sort of so for those who may not be familiar with the Health Data Coalition, it is a nonprofit organization that supports family physicians and nurse practitioners in collecting. So it works through their electronic health record to help them look at their data and run sort of reports on how their care is going. And the Health Data Coalition is also looking at how those clinics that have teams, how their care as a team is actually going and trying to engage not just the family physicians and nurse practitioners in that quality improvement work, but also the entire team. And so we'd love to see how that could be perhaps used to support this work as well. And then the other piece, again, perhaps a little biased in that I was or related to the College of Family Physicians, there's a new assessment criteria requirement for CPD. And QI is actually one of those areas where you can get assessment credits. So this is where, I agree with you that QI is perhaps intimidating and sounds like more work. And we do it generally. However, by labeling it QI, you could actually potentially get those assessment credits, which would be an advantage for your maintaining your license. So sorry. Those were two things that came forwards in my brain, and thinking of all the overlap of all the things that are going on in primary care. Okay. Did anybody else have any, so enough of my rambling. I'm going to look to the group that's here, and get you to think about your breakouts. Were you in the middle of a conversation that you really would like to finish? Was there a key topic or a key question that you were left with your hand raised? By all means, this is an opportunity to bring those forwards, and we can continue with those sort of key ideas that came forward in your breakout.
Since nobody wants to jump in, I'll just go right ahead. I don't know who was speaking last in the quality improvement group, but there was someone who was cut off in the middle of saying something as we were being kicked back to Kansas, as I call it, at the end of the quality improvement group. I don't know if that person is still with us, but whoever you were, I would be interested to hear the rest of what you had to say if you are still here somewhere. And maybe that person has left or is feeling shy.
I think they've already left, Kent, unfortunately.
Okay.
Yeah.
Yeah. Too bad.
Yeah, it's definitely an interesting point about like patient-centered approach. But unfortunately, we didn't hear the end.
Right.
I'd be curious about a patient-partnered approach. So what would patients in the clinic that I work in be interested in looking at quality improvement of? And start from there.
A point that I made earlier that might be of interest to the larger group, even though I also do come with with a lived experience perspective combined with my many other intersecting perspectives. I had mentioned that just within recent days, my mom and I both had attempted to visit the urgent primary care center here in North Van. And many years ago, back about 2017, I was involved in opening one of the first urgent primary care centers under the auspices of the Providence Healthcare team. But I had no idea that the urgent primary care center here essentially doles out the care for the day in a food bank visit sort of way. So even though they are open ostensibly between about 8 a.m. and 8 p.m., if you don't go and queue up in the morning, they have given out all of their care slots for the day, as my mom and I found out when we showed up there about noon or during the lunch hour. And then they will just send people off to the hospital or tell them to come back tomorrow if they're not able to reach their primary care doctor today, which wasn't anything like what either of us was expecting. And I don't think that was the original intention of those systems.
Definitely not. And we're hoping that Kent, I'm hoping that with the new, longitudinal compensation model and more patients ideally becoming attached, fewer demands on that sort of longitudinal care on the urgent primary care will then open it up more for urgent primary care that is truly urgent, not stand in line for a next day appointment. And then I think there are lots of things that we need to look at that we have looked at in the past, like open access bookings and things like that, that is a bit of a cultural shift, as well as team-based care. We're hoping that by broadening the team, will increase access. So lots of, it's a broken system, my goodness, and that was not the intent.
In this case, my mom and I both came back, in my case, from I was traveling into the States attending a conference, and because we were not able to use the urgent primary care center in the way that we had thought, care was delayed by about 4 days before we could get back to each of our own primary care. And, when dealing with the effects of an upper respiratory infection, 4 days of treatment or not makes a big difference.
Yeah, yeah, for sure. John, I see your hand.
Yeah, I was just going to say that I'm both a social worker and a patient. One of the things that one of the pieces of feedback I got very early on in my career from patients when I started doing research was, what's in this for me? So where am I going to get the feedback on this, and how is this going to improve my experience as a patient? So, which speaks to exactly what Kent is just talking about, I think, which is, if you want to engage people, and you engage them right at the outset, which is where they should be engaged, of course, then it's going to be about how is the information that you're going to provide to me as a researcher or as a clinician going to improve the quality of care for you and or your family, for example. I think and so over the years, what I've discovered, and you've probably all had this experience too, is that there's basically two kinds of research participants. There's the ones who just can't wait to share information, and they'll just jump up, and it doesn't matter what it is, they're there. And those people are great and they're wonderful. And I'm kind of like that too when I'm a patient. But then the other group are the people who want to know, okay, what are you going to do with this information, and how is it going to make things better? So there's my 2 bits worth.
Yeah, I agree. And I don't think we do that great a job sometimes of closing that loop, of feeding it back to, especially when it doesn't necessarily come with those great results that we had hoped. Our research isn't quite as positive as we had expected, and so sometimes we shy away from feeding that back. Whereas I think that that's really important for the engaged patients to also, who have contributed to understand, we tried this and actually it didn't do what we had hoped it was going to do. Now what?
Yeah, no, exactly. And I still make the mistake of having a moment of intellectual curiosity about something and thinking, oh, we should do some research on this. And then thinking, oh, wait a second, like, how are the patients going to perceive this, right? Like, so yeah, it's interesting.
There's something that I'm curious about. I think I'm always interested in hearing experiences and success stories where patients have been involved in developing the evaluation and contributing to the evaluation. And I think it's inspiring when patients are involved in creating the evaluation framework, when considering, like, how do you measure success? And I've seen sort of examples of that. I'd see less examples where patients have been involved in saying, what specifically is success? What are our targets? What are we aiming for as part of this whole evaluation process? And I'm always curious to hear stories of anyone who's seen that happen.
Angela, were patients engaged in determining those evaluation metrics?
Yeah, so I was just going to add a bit of context around that. So something like thinking about our work at the ISU, we have some patient partners that we have great partnerships with, such as Kent, and others where we have those longitudinal relationships and kind of involve patients in a lot of the work that we do. And so forming those longitudinal relationships, I think allows for kind of comfort and trust in terms of sharing feedback and ideas around like a survey tool or an idea or a project, things like that. And we tried to really keep patients at the forefront. So we did have some patient feedback on the survey tool as part of our kind of engagement process on the tools. So we had a process where we did some research on what tools exist out there. And then we brought some healthcare partners and patient partners into the work to talk about not just kind of wording of survey questions, but actually talking about what information is going to come from those questions. So we built out some kind of mock data things where we would say, okay, so let's say we ask these questions, what does the data output actually look like? So kind of reverse engineering it a bit. And then looking at the question wording as well, kind of recognizing that wording is really important, but first trying to focus on the kind of concepts and overall ideas that are coming out of it. Elke, I don't know if you want to add anything about that process of kind of working with the mock data and going backwards.
I think you've explained it well. Just kind of seeing, just making sure that we're not just asking questions for the sake of asking questions. So really working through before we put a survey together, what data are we going to be able to get out of the survey, and is it useful? Is it something that is going to be usable? And so really making sure that all of the questions that we're asking do have use for teams and patients in terms of like the evaluation.
Yeah, and especially when we're thinking about demographic questions, we spend a lot of time thinking about what demographics we would actually use in terms of analysis and things like that, to make sure that we're not asking people to provide more information that they would feel comfortable with.
Kent?
Yeah, I was just going to respond to Ben's comment earlier about what does success look like? And, this seems like the totally obvious low-hanging fruit style answer, but I think obviously part of what success looks like is improved patient outcomes. And then we have to figure out how do we measure improved patient outcomes? What qualifies as improved patient outcomes? And how do we count them? But I think improved patient outcomes obviously is a big part of the success picture, or should be.
I had a question for the group, and I don't know if you can share it. So in your constructive workshops with the survey feedback, were there QI projects that came up with respect to patient experience? And can you share some of the topics or the ideas around QI and patient experience?
Yeah, for sure. Yeah, a couple of ones that came up more than once. One of them was around how clinics and team members are communicating the team-based care approach to patients. So as part of the survey, we asked patients if they're aware that the clinic that they're at has a team-based approach. Some of these patients, it might have been their first time at the clinic, others might be attached and have been several times. So that context is important there. But yeah, we tried to kind of understand how it's being communicated. So whether that's through kind of like newsletters, email communication, whether there's posters in the clinic waiting room, whether it's something that comes up when patients first see a provider at the clinic or when other providers are brought into their care team. So we looked at that, and it does look quite different across clinics. Yeah, talk to them a little bit about some strategies to improve that. And I think that was an area that people were kind of excited to work on in terms of that clear communication piece. and thought about some ideas. And we actually have a patient communications checklist that was developed through some of our other work that just goes through some considerations in terms of communicating the team-based care approach with patients. Another thing around patient communication that came up a couple of times is having clear expectations around how to make appointments, clinic hours, how to get care after hours. So really thinking about, how is that being communicated on the clinic website, if it is, or in other clinic communications. And we had some wonderful PSP coaches who were able to share great ideas that they've worked with other clinics with. So here's this email template that might work for you as well, that's worked with another clinic, things like that. And Kent, I was thinking about that when you were sharing your story. Just being really clear what the process is. Do you have to come in first thing in the morning? Do you have to call? What does that look like?
Well, and even more ironically, there are multiples of primary care offices, at least in this area, and I would imagine potentially across the Lower Mainland, that say if you need care after hours, go to an urgent primary care center. But then when you go to the urgent primary care centers, at least the one that I've been to, they're using a what I think of as a food bank style model. And they say that it's because they have short staff there, but I didn't get a sense of, what's the ideal conception of how they would like to operate, but they're under-resourced enough that they can't realize that right now.
I like the idea of a communication checklist that gets us. I mean, I find I work with a lot of clinics who are team-based, but you ask even the providers within them, and they may not, identify as a team or use the language that would even share that it's, oh yeah, it's a team, it's a team clinic. So I would love if you can, are you able to share that checklist?
Yeah, so I believe it's on the Team-Based Care BC website. I'm just trying to pull it up here, but if anybody else on the ISU team has the link ready, we can pop it in the chat. Oh, of course, there's a thank you.
Yeah, it's great. I mean, for learners too, right? Because trying to let them understand that you're working within a team and you're part of this team, and that's part of the learning as well, is what's your role on that team, and yet we don't do that well. 2004, I'm dating myself. I did a bunch of focus groups with groups of patients, trying to say, how would you feel about a shift to team-based care? There was great feedback with respect to how to do that effectively, and how they would feel about it, and they would feel better if, and the warm handoff was a big piece of it, right? It was, if you're shifting from being the person that I see all the time to being somebody I see every now and then another provider, they were always, the common response was, as long as you introduced me or indicated that this is a colleague or a part of your team, then I'm fine. And I'm hoping that shifts as team-based care becomes more and more common.
One of the things that I think is important to emphasize again in this discussion, that we have talked about a fair amount, I know even in the work that I've done contributing to the ISU, is the difference between, team-based care teams and teams that are merely co-located, meaning that their offices might be next to each other or nearby or across the parking lot, but they don't necessarily know that each other is there, and they're not collaborating in a patient care sense.
Yeah, I think that's something we see quite often. We always fall back on the definition of teams as people who work together and how they want to work together.
Exactly. I was just going to say that.
Yes, our classic ISU phrasing of that. Yeah, which has been really interesting to explore through this evaluation as we've onboarded teams, kind of really understanding how they work together and how they've defined who's part of their team, how they've kind of gone about creating a purpose and vision for the team and clear roles and accountabilities and that type of thing. Christy, I was thinking about what you had mentioned before, the conversations that we had with clinics around communicating the team-based care approach to patients, and that also is from some of our other work that we do at the ISU. It brought up some or started some interesting discussions around how that can help patients really be part of their own care decisions, right? If they know what other providers are part of their team, maybe they can self-identify like, oh, that would actually be a really good provider for me to connect with. But if they don't know that person exists, then they can't really do that for themselves. But then also I know, clinics might be trying to manage capacity for providers on the team, right? So how do you find that balance of, okay, we perhaps don't have that many hours for our nurse, for example. How do we make sure, that everyone who needs to see the nurse is seeing the nurse, but that doesn't create kind of a backlog or a wait list, and how to manage those situations.
And then we get into a whole other topic of role overlap. And so if
Yes,
the
yeah.
nurse is at capacity, who else has the same skill set that overlaps that we could triage and work with? And then it's team function, and how do you do that and communicate those shared responsibilities? Oh,
Exactly. It's
so
all
much
connected.
fun. Exactly.
I also, I also, if I can jump in, there's a QI opportunity in there as well, to capture if more patients want to see the nurse or are asking to, and there isn't capacity, there's a potential need that's not being met, that can be identified and can become part of the QI process in that, and potential data that can be used then to advocate for the addition of another nurse on the team or the funding for that.
Can I bring forward the a comment in the chat? So I always define team as including the patient and family. And lots of likes on that one. I agree completely. However, I think there's a spectrum of where that person, where anybody wants to fit in the team. So there are some patients who are very comfortable and interested in leading the team and quarterbacking their own care. They feel as though that helps them manage and control their care. So that's great. There are some that are in a different place and perhaps would just like to have somebody else take care of them. And I always, so while yes, I always consider the patient as part of the team, figuring out having that conversation about what that means to them, and it may change because it may change based on the issue that they're seeking care for. Anyway, I'm opening up that conversation. Those are thoughts that stimulated with me. And Kent, I see your hand up.
Yeah, you basically said most of what I was, going to say, but I just wanted to emphasize the idea that, like you said, as much as we have, talked over and over about this idea of having the patient be part of their own care team, there are situations where, you know, patients may choose to actually make fewer decisions. And as part of their sort of surrendering into care, that, I mean, because part of needing to be helped can also mean, decision support and this kind of thing. So I think that as much as we have emphasized the idea of patients as part of their own care teams, maybe I don't want to really say less of that, but just don't forget the idea of informed shared decision making, let's call it.
Thank you. Angela, is there a question on the patient experiences? I know you ask about whether they feel as though they're in a team or something like that. Is there a part there of do they play a role on that team, or have you gotten into that?
Yeah, so we framed it a bit differently, but there are some questions. So we have some survey questions that are meant for anyone completing the survey. So that could be patients who are visiting this clinic or receiving care for the first time, and others who might be attached and receiving more longitudinal care. So within that set of questions, we have some person-centered care focused questions that do ask about how patients feel around their involvement in terms of making decisions about their care, and some of those other kind of classic person-centered care questions about, involving patients and family as much as they want to, having the information that they need, feeling heard, listened to, that type of thing. Just to make it easier for the patients to complete it, we haven't framed it as patients are specifically part of the care team, but that is how we see it, right? But just for the survey purpose, those questions about the patient perception on the team is for patients who have visited the clinic or received care more than once. And yeah, that's really focused on the staff and providers as part of their care team. So that is something that we agree with and kind of frames our work, but we've just framed it a bit differently in the patient survey.
Great, thank you. I'm gonna pause and see if there are any other aha moments.
I'll just add as well, if anybody wants to know more about the other patient tools as well, or other survey tools, sorry, as well, or the evaluation, I'm happy to answer some specific questions now, or also happy to talk at another point. I know that Ada has put in the chat the link to the recruitment poster for the evaluation, which has some information about it and how to get in contact. Please feel free to share this with others who might be interested, and I'll put my email and our general ISU email in the chat as well.
That's great, thank you. So I think I'm gonna wrap up, and that includes putting a lot more links in the chat. But they will also be emailed to you. So I really want to thank the ISU team for presenting today and sharing your evaluation, and I look forward to touching base again and hearing how it's going in phase 2, and also looking at some of the stuff that you've already come up with. I really appreciate it. I thank all of you and those tried and true who are staying around to the very end. Thank you. I think it's been a great conversation, and so UBC Health and the TBC at UBC Network has a few announcements before we all sign off, and it's one, if you're interested in sharing your work, we do have, we're happy to work with you. There is sort of a form to fill out with respect to sharing your work on the TBC at UBC Network. And we'll have a link, and it will also come in an email. The other is we have a conference in November. Where is the patient's voice? And it is occurring November 12th to 15th. It's the 3rd international conference. They occur every 10 years. And registration is now open. And it is really focused on patient involvement in health and social care education. And there's also a link for that. We're also looking for expressions of interest for a working group that will help design interprofessional education champions program. And this program is aimed at supporting interprofessional education in practice settings through professional development, funding, recognition opportunities, and resource sharing. And the working group will begin meeting in the fall. So if you would like to connect with that, we have a point person, Brenda Gonzalez at ubc.ca, also posted. And finally, we are going to take a break for the summer, and we will resume the TBC at UBC Network in the fall with our next event taking place sometime in October. If you have not yet signed up for the network to receive those notices and the save the dates when we finalize that date, there's a link, and we will also share that link again in an email. And we have a feedback survey, which we will email. And also if there's a chat, if the link is in the chat, that would be great. We do use your feedback to try and improve each of the sessions. And so thanks everybody. And I hope that you all have a wonderful afternoon and summer.